So good morning everyone. Welcome to the first session of the second day of the conference, and I hope you must have recovered from the yesterday's tiredness of the various lectures we had. So the first topic which we are going to discuss today is one of the most pertinent topic which we as neonatologists or perinatologists should know, which can help our preterm babies survive better. So as we all know that the tiniest of the preterm undergo a lot of problems during our NICU stay. But we all know that they are vulnerable, but they are salvageable. They undergo a lot of morbidities like acute lung injury, chronic lung injury, ROP, necrotizing enterocolitis, neurological injuries. But what are the interventions which have come up in a big way, which have been developed lately to help these newborns survive better? So let me take each one of them. Some of the antenatal interventions like antenatal steroids, antenatal MAC cells, antenatal antibiotics, postnatal interventions like delayed cord clamping, the most important and the pertinent, that is the thermoregulation of these newborns, delivery room non-invasive ventilations, that is delivery room CPAP, and this delivery room saturation targets. So these are the important interventions which have come up in big way and helped our preterm survive much better. So let's take each one of them. Antenatal steroids. So what antenatal steroids to be given? What should be the timings of the antenatal steroids? Who are the candidates who should receive antenatal steroids? What preparation of antenatal steroid, whether it should be the dexamethasone or it should be the betamethasone? What should be the dose of these antenatal steroids, and should we repeat the dose of antenatal steroids? So I think as neonatologists, we should now start questioning our obstetric colleagues that have you covered this newborn or this pregnancy who's going to deliver preterm with antenatal steroids, because antenatal steroids have shown to be a huge efficacious thing. If you can see all these numbers, there was a significant reduction in the perinatal deaths by almost 28%. Reduction in the neonatal death by almost 21%, reduction in RDS by 34%, moderate severe RDS reduction, IVH, NEC, need for ventilation, infection in 48 hours. So all these have been the significant benefits of antenatal steroids. So what should be the protocol for antenatal steroids? We all know that we use either antenatal betamethasone or dexamethasone, but who should be the candidate for antenatal betamethasone or dexamethasone? So as per the latest guidelines which have come up in August 2017, that is in the ACOG, American College of Obstetrics and Gynecology, which suggests that any pregnancy who is from 24 to 33 plus 6 weeks of gestation should receive a single course of steroid. Between 23 to 23 plus 6. This is a gestation which has to be specific for the country, specific for the situation, specific for the place where you are working. So whether it is like based on the decision of the parents that whether they want to go ahead with the resuscitation of this baby, it should be offered. Now, there's another very pertinent issue, is that is use of antenatal steroid in our late preterm babies. Late preterms are the babies who are from 34 weeks of gestation to 36 plus 6 weeks of gestation. So as per the latest ACOG guidelines, a single course of antenatal steroid should be offered to these ones who are going to deliver, but they should not have received any previous course of antenatal steroids. So one course should be offered to this gestation babies. Now what should be the timing of antenatal steroids? As you can see, if offered within less than 24 hours, it showed reduction in the fetal and neonatal death, but however there was not significant reduction in severe morbidities. Less than 48 hours, it reduced both. 1 to 7 days, it decreased severe morbidities. More than 7 days, no effect. So the best time to offer antenatal steroid when a preterm delivery is imminent within first 7 days of starting the treatment, including if it is within first 24 hours. So even if you are able to give one dose of steroid, it should be offered to that pregnancy who is going to deliver imminently. So any delivery within 24 hours up to 7 days should be offered antenatal steroids. So what should be the dose and what should be the repetition course of these antenatal steroids? Most commonly, as you know, we use either betamethasone or dexamethasone. The betamethasone which we use is normally the dose is 12 milligram, which is given 24 hours apart, 2 doses. And dexamethasone is 6 milligram, which is given every 12 hourly, and it is 4 doses which is given in total. So now if you have given one complete course of antenatal steroid, what should be the morality that now the delivery did not happen? So when should be the repeat course of antenatal steroid be given? Now the lady has come back again with an imminent delivery after 7 days of the course. So should we repeat the course of antenatal steroid or not? So the literature says that repeat course of antenatal steroid showed a reduction in RDS by almost 17%, and the number needed to treat, that is that if we treat one baby, the 17 babies will be prevented of respiratory distress, and the severe infant outcomes were also improved. So there are some advantages of repeat course of antenatal steroid, that is there was reduction in RDS, there was a reduction in composite infant morbidity. However, what are the risks? The most important risk with this is that the child may turn out to have small for gestation age, might have reduced head circumference, the pregnancy may turn to have smaller placenta, and there are some high risk of cerebral palsy with the repeat course of antenatal steroid. So how should we weigh the balance between the two? So the way the ACOG has given its recommendation is that a single repeat course of steroid, if the lady has presented again with the gestation age which is less than 34 weeks and the previous course was given 7 to 14 days prior, in the settings of PPROM, that is there is a preterm premature rupture of membrane, the repeat course role is controversial. Still now there is no proven benefit, or the hazards have not been proven whether in such setting the repeat course should be given. But definitely if 7 to 14 days have surpassed and the gestation of the baby is less than 34 weeks, we should give the benefit of repeat course of antenatal steroid. Now the most important and again the pertinent issue is what should be the type of steroid which should be given. That is, you should give a dexamethasone or betamethasone. So what the betamethasone is available in the Western world is betamethasone acetate and phosphate. Whereas like in our part of the world, like that is in India, what we have is betamethasone phosphate only. Betamethasone phosphate is short acting, whereas the Western world has betamethasone acetate plus phosphate, which is both short and long acting. So all the studies and the literature are with betamethasone acetate and phosphate. Now dexamethasone is short acting, however dexamethasone has been found to be equally efficacious in betamethasone, and dexamethasone is easily available. So as per the latest guidelines which have been given by the government of India is that dexamethasone can be preferred over betamethasone because of the easy availability and the kind of the preparation of the betamethasone which we in India we have is not same as the Western world. But if we come to the literature, there have been kind of a world war going on between the literatures which have come up between betamethasone and dexamethasone. There were a huge lot of literature which came up that dexamethasone was inferior to betamethasone, but of late there are a lot of literature. In 2013 also there is a meta-analysis which has come up which has shown that dexamethasone was associated with reduced risk of IVH, and there was no difference of severe IVH between dexa and beta, and there was no statistical differences between the primary outcomes, that is RDS, and the perinatal death between beta and dexa. So this proves that beta is no inferior to the dexamethasone. So what does the authorities or the bodies have to say about beta and dexa? WHO 2015 guidelines, beta is equally efficacious as dexa. ACOG 2017, equally efficacious. RCOG 2010, equally efficacious. So it should be country specific, what kind of preparation you have, but they are both equally efficacious. Whatever is easily available in your country, you can go ahead with using that. So I think we have covered antenatal steroids and I think we all should be clear, any pregnancy who has come with less than 34 weeks of gestation, from 24 to 34 weeks of gestation should be offered one course of antenatal steroid. Repeat course should be offered if it has 7 to 14 days has surpassed the previous course of antenatal steroid. Now let's come to one of the most important intervention, which is again have come up in big way to help in the neurological improvement of our babies, especially the preterm ones. We all know that the cerebral palsy risk is very high in babies who are less than 28 weeks of gestation. So antenatal magnesium sulfate. Again, there is lot of evidence which are these are the various trials which have shown that antenatal magnesium sulfate reduced the risk of cerebral palsy. If you can see all these studies, there was a significant reduction in the cerebral palsy rate with the use of antenatal magnesium sulfate. So again, this is a meta-analysis of those studies. If you can see death of cerebral palsy, almost there was a 15% reduction in cerebral palsy and death. There was a 29 and 19% reduction in cerebral palsy alone with the use of antenatal magnesium sulfate. Now, so the literature says that magnesium sulfate should be offered to all women who are suspected to have preterm births, and the number needed to treat is like if you treat one pregnancy, if you treat 63 pregnancy with magnesium sulfate, you will prevent one case of cerebral palsy. So who are the cases in which the antenatal magnesium sulfate should be offered? So WHO guidelines and various other guidelines have come up that all pregnancies who come up with imminent deliveries, that is less than 32 weeks of gestation, and the delivery is imminent in next 24 hours, should be offered antenatal magnesium sulfate. Now, again, there are a lot of studies which have come up what should be the dose, but categorically what we use is 4 grams of loading of magnesium sulfate over 20 to 30 minutes or 1 hour maximum, and followed by maintenance, that is 1 gram per hour for the next 24 hours. So this is the unanimous dose which we use for antenatal magnesium sulfate. So antenatal antibiotics, there's again a lot of literature about the role of antenatal antibiotics. What the literature has to say that there is no role of antenatal antibiotics in preterm labor. Only in preterm labor. In fact, there was an increased risk of functional impairment and cerebral palsy if the antibiotics were used. The role of antibiotics should be used only for PPROM, that is pre-labor rupture of membranes. Increase time to delivery, reduction of infection, and improve respiratory function with the use of antibiotics. Now let's come to the postnatal interventions. We know that lot of us are involved in taking care of the preterm babies. So how and what we can do to help in delivery room for these babies? What are the gentler strategies? So the gentler strategies which are being used are delayed cord clamping, thermoregulation of these babies, respiratory support in form of non-invasive ventilation, and strict oxygen saturation targets. So how many of you in Egypt in the delivery room have the pulse oximeter monitors and you target your oxygen saturations and you know what should be the target saturations for these babies and not just put these babies under oxygen? Yeah, so we all have to be very strict about it. We all should have the algorithms of the oxygen saturation targets. So I'll be dealing with each one of them. And how many of you are doing delayed cord clamping? So every delivery should be offered. Like almost 4 years back, we never used to do delayed cord clamping. But now our obstetricians are actually scared of us. Every delivery, whether it is a term delivery or whether it is a preterm delivery, we offer delayed cord clamping because it has been found to have so many advantages for the delayed cord clamping. So what is actually delayed cord clamping? So there has been various definitions which have been put forward for the delayed cord clamping. The WHO in 2012 suggested that delay of 1 to 3 minutes after the delivery of the baby. ACOG 2017, which is the latest guideline, suggests 30 to 60 seconds of delay. ILCOD, that is the NRP 2015, longer than 30 seconds, and RCOG 2009 suggested should not be clamped earlier than it is necessary based on the clinical situation. So, whatever you use, but practically we all are using around 30 to 60 seconds of delayed cord clamping, and we all must offer to all, whether it is preterm babies or full-term babies. So what are the advantages of delayed cord clamping? So it has a lot of hematological benefits. As you can see that if the delayed cord clamping is done with even 60 seconds of delay. There was 16 ml per kg of higher blood volume which was given to the baby if there was a delay. If this you can see, this is the infant blood volume and this is the residual blood volume in the placenta. So as we delayed it by 60 seconds, there was almost increase by 16 ml per kg of the blood volume. The other advantages which have been associated with delayed cord clamping are there is a reduction in rate of periventricular hemorrhages or interventricular hemorrhages. There is an improved cardiovascular stability of these preterm babies. They have much better blood pressures. They have much better blood volumes as you've seen in the last slide. They require lesser transfusions. And there's also a reduction in the rate of necrotizing enterocolitis. So these are the short-term benefits for our preterm, but it also has long-term benefits when they go on to the infancy. So these are the short-term benefits: reduction in mortality, IVH, transfusions for anemia, number of transfusions, need for inotrope, NEC, and the need for jaundice needing phototherapy did not increase. So all these have been the benefits of delayed cord clamping, and the long-term benefits also have been shown that on the Bailey's infant scale 3, these babies with the delayed cord clamping, they had better motor scores in babies who were born less than 32 weeks of gestation. So this is a small algorithm which I have created, that whether it's a term or preterm baby, note down the time of the birth, place the baby on the mother's abdomen or at the level of introitus, dry the baby. If the baby is breathing and crying, yes, count for 20 to 30 or whatever protocol you are following, cover the baby, clamp the cord at 30 to 60 seconds. If the baby is not crying, then clamp the cord immediately. And if there is which is a contraindication for delayed cord clamping, if there is antepartum hemorrhage or if it's a monochorionic twins, then clamp the cord immediately. So this is the only contraindication which we use. So as per the AAP 2015, delayed cord clamping longer than 30 seconds is reasonable for both term and preterm babies who do not require resuscitation at birth. There is insufficient evidence on delayed cord clamping for infants who require resuscitation at birth. Now, after delayed cord clamping, we also need to talk about thermoregulation. Thermoregulation again is one of the most important things which we usually ignore at times. We know that with every degree fall in the temperature, the morbidity increases by almost 20%. So if you see, 36% of the neonates born between 4 to 25 weeks had admission temperature less than 35. That was as per the Epicure, which was a huge study. And 28% of the VLB newborns had admission rates of 36, which is as per the Vermont-Oxford network guidelines. So, like one of our hospitals in India, that's AIMS, when we observed over a period of 3 months and we recorded just as a protocol, we found that most of the babies were coming with a temperature of almost 35.9 degrees. So until unless you record, you will not get to know that your babies are coming in a hypothermic state just from the delivery, which might be next door to your NICU, but they might be hypothermic. So what all we can do to prevent reduce this hypothermia? So there are various strategies. Number one, we should ensure that it is warm delivery room. Radiant warmers are at the highest output. The preterm babies should be received in polyethylene wraps. I hope you all must be using the polyethylene wraps for receiving the preterm babies. Warming mattresses can be used. There should be pre-warmed gases used in the delivery room, and the transport should happen in the pre-warmed incubators or isolates. So these are the transformer mattresses which we are commonly using for the transport of our babies. And there is again enough evidence for the use of the plastic wraps or the plastic bags. If you can see, this is the meta-analysis which was done in 2009, and it showed that there was a significant reduction in hypothermia in babies who were born less than 29 weeks of gestation with the use of polyethylene wraps in these babies. So almost there was a 27% reduction of hypothermia, and with the treatment of 4 babies we could prevent one episode of hypothermia. There was no significant reduction in the duration of oxygen therapy, major brain injury, or the duration of hospitalization and death with the use of polyethylene wrap. So now, last but not the least, that is delivery room CPAP. There's again lot of evidence which has shown
that instead of intubating the baby, use delivery room CPAP. If the baby is spontaneously breathing and the baby is not apneic, then there has been significant reduction in lot of morbidities like use of surfactant leading to pneumothorax, death, BPD. All these morbidities reduce if you use practically non-invasive ventilation as compared to the invasive mode of ventilation. So again, this shows that there was a reduction in death or BPD in babies in case of, again, only in BPD and death in BPD. Both, there was a significant reduction with the use of the nasal ventilation. So, as per the Alan Jobe, who is considered father of the respiratory physiology, there is perhaps nothing more dangerous for a preterm lung than an anxious physician with an endotracheal tube and the bag in the hand. So, the summary is that CPAP started soon after birth is a very important strategy that appears to reduce BPD or death and should be used as an alternative to prophylactic or early surfactant approach. Infants treated with early CPAP instead of early surfactant are not at increased risk of adverse outcome from delaying or eliminating the surfactant administration, and early CPAP is recommended except for those who develop respiratory failure or required intubation should receive surfactant, that too as early as possible. Now, last but not the least, what should be the saturation targets? As you all know, these are the standard targeted free ductal saturations which are being given by NRP 2015, and you can see at 10 minutes your baby should have a target of saturation of 85 to 95%. Not that the baby is born and the baby should be suddenly found to be pink. So we all must maintain our saturation targets in the delivery room. Similarly, for preterm babies, the Dawson normograms have been provided, and we should have these normograms in the delivery room so that we can guide that the saturation should not be 90-95% for the babies who are born preterm. So we commonly use blenders in our delivery room to titrate the oxygen saturations for these babies. So as per the systematic review by the Soxted, in 2014, there was a significant reduction in the morbidities like death and RDS with the oxygen saturation targets being with the oxygen being used less than 65% as compared to like 30%. So with the use of 30% FiO2s, there was a reduction in morbidities as compared to the saturations, as compared to the FiO2 of 65%. So the latest NRP 2015 guidelines recommend that oximetry should be used for resuscitation, use of blenders in delivery room when delivering oxygen, resuscitation of preterm less than 35 weeks should be initiated with low oxygen, that is 21 to 30%, and be titrated to achieve the oxygen saturation targets. Using resuscitation of preterms with high oxygen, that is 65% or greater, is not at all recommended. So, the summary is that it is a continuum of care. The care does not start with the delivery room. The care starts from the antenatal interventions. The use of antenatal antibiotics for PPROM, the use of tocolytics to prevent preterm delivery, strong use of antenatal steroids, use of transport and magnesium antenatal mag self in delivery room, delayed cord clamping, delivery room CPAP, saturation targets, and in NICU, strong use of again CPAP, non-invasive therapy, caffeines, and the saturation targets in the NICU. So this summarizes the whole talk that we have a continuum from antenatal to the postnatal to prevent injuries in these preterm babies. Thank you.